Welcome to one of the two parallel sessions that we'll be having before the closure. This session focuses on ending HIV and AIDS among adolescents, where the solution lies. This session will look at solutions primarily, but for those of you that are fans of detective movies, we always have a bad cop and a good cop. I'll be playing the bad cop, talking about the problems that we're addressing, and my panelists here will be playing the good cops. They'll be giving us solutions and ideas about how to address these issues. First of all, let me introduce the fellow panelists. Myself, I'm Ian Askey. I'm the Director of the Reproductive Health and Research Department at the World Health Organization, based in Geneva. To my left, we have Maluba Habanyama. Maluba is a journalism student who was born HIV positive and lost both her parents to the virus. She's volunteered and consulted with numerous AIDS service organizations, including the Women's Health in Women's Hands, Ontario HIV Treatment Network, Casey House, and Youth CO. Today, Maluba is the Canadian Foundation for AIDS Research National Youth Ambassador, and she serves on 3 boards of directors for health organizations. And she's a student, as I mentioned, at Ryerson University. Next to her is Jean-Pierre Zilli. Jean-Pierre is a technical advisor with Save the Children Canada, and he focuses on health and nutrition programming primarily in the sub-Saharan African region. Before joining Save the Children in last year, or 2 years ago, Jean-Pierre spent 9 years working in South Africa, Malawi, Lesotho, and Mozambique to provide technical assistance in HIV/AIDS programming through producing the content on weekly national broadcasts on TV and radio platforms to promote treatment literacy among youth living with HIV and to evaluate the roles that community health workers could have in addressing preventing maternal-child transmission. Jean-Pierre holds an MPH degree from the University of Cape Town. And at the far end is Mark Gachuga. Mark is a Kenyan youth advocate with 6 years of experience in advocacy in sexual and reproductive health and rights. And he was the founder of the Young People Advocating for Health NGO. Mark's worked with many policymakers and young people through advocacy campaigns. He was instrumental in the launch of the global All In campaign, which aims to fight against HIV/AIDS among adolescents. He's also a Women Deliver young leader and currently working with young people's institutions and the media to create a movement of young people who are aware of their sexual and reproductive health and rights. So to set the scene, let me say a little bit about where we are at the moment with HIV and AIDS, but also with other sexually transmitted and maternal-child transmitted infections. At the moment, there are approximately, and these are estimates, 1.8 million adolescents aged 10 to 19 living with HIV, over half of which, 56% of which are girls. These numbers are also important because every hour there are approximately 29 new acquisitions, 29 adolescents, children acquire HIV. So every year, approximately 250,000 new infections. And this is primarily in sub-Saharan Africa. 65% of all new acquisitions are among girls, and of those girls, 80% of them live in sub-Saharan Africa. So these days, the new infections are very focused on a particular population of young adolescents, young girls, primarily those living in sub-Saharan Africa. But HIV is not just a sexually transmitted infection. As you'll hear from Maluba, it's also transmitted, it can also be transmitted during pregnancy, labor, delivery, and breastfeeding. In that sense, approximately the transmission rates are anywhere between 15 to 45%. But as many of you know, over the years, there's been a vast efforts to try to reduce this. And now with treatment with antiretrovirals, this can come down to way below 5% of cases. However, what it does mean is that currently there are, as I said earlier, about 1.8 million adolescents living with HIV, but at the moment, only about half of those are currently receiving treatment. Latest figures were about 800 and so thousand on treatment. So still about half are not receiving treatment. And this may be because they don't know they're HIV positive or they're not able to access the treatment services. But also I'd like to take the opportunity for this session to say a bit about other sexually transmitted infections and infections that are transmitted from mother to child, because here the numbers get very big. When we look at curable STIs, those that are STIs that are caused by bacteria, every year there are approximately, or estimated to be, 357 million cases every year of curable STIs, that is trichomonas, chlamydia, gonorrhea, and syphilis. That's every year, but then you have to add to those numbers that there are approximately 500 million people living with herpes simplex virus, and approximately 290 or maybe 300 million people, women primarily, living with HPV, which we heard about earlier today. So in terms of other STIs, we're looking at probably about 1 billion people in the world affected by STIs. And this has profound impacts on life, not just in terms of physical, psychological, and social consequences of living with these types of infections. This is a very important aspect for the individual, for their family, for society. But there are many other impacts that we need to consider and have to be taken into account when we've been talking earlier about programs and policies. One of them is the cost. We don't know much about the costs involved with this, but a recent study by CDC in the US found that every year there are approximately 110 million cases of STIs in the US. Treating and looking after those 110 million cases cost the US health system $16 billion. This is not a small cost for the health system. So if that's the cost in the US, imagine that escalated globally. Other STIs can also not just cause problems in terms from an infection perspective, but they also can be fatal in many circumstances, particularly for fetal and neonatal deaths, where we know that syphilis in pregnancy can lead every year to 300,000 fetal or neonatal deaths, and a further 215,000 infants at risk of death or morbidities from syphilis during pregnancy. As we heard earlier in the presentation about HPV, at the moment there are many millions of women and girls living with HPV, and every year over 750,000 deaths from cervical cancer. Cervical cancer is usually classified as a non-communicable disease, one of the NCDs. But in this case, it really often isn't. It's a communicable disease through HPV, and so we do need to bear that in mind going forwards. We also have to bear in mind that STIs, including HIV, have major implications for fertility. Chlamydia, gonorrhea particularly, are important determinants and associated with infertility. And so people infected with these infections may also have problems conceiving. And finally, these other STIs often interact with and provide an increased likelihood of acquiring HIV. Recent research that our department carried out showed that people infected with herpes can have up to 8 times greater risk of acquiring HIV than people without herpes. And given that in East and Southern Africa, almost 50% of people living in that region have herpes. This is part of the reason why HIV is still very prevalent in East and Southern Africa. So that's the doom and the gloom and the bad cop and the problem we face. But there's been a lot of experience over the last 30 years, particularly in addressing HIV and AIDS. And we're going to hear from our panelists about some of these experiences. And it's important to bear in mind that the experiences that we're going to hear about primarily from an HIV perspective, but also we need to think about how these carry over to other infections. HIV field has been relatively speaking, very well resourced compared certainly with other STIs and with other aspects of sexual and reproductive health. And there is a lot of experience, but we're still living with a major challenging situation. So I'd like to invite the panelists to provide us with some feedback and some thoughts around their experiences. And first I'd like to start with the man in the middle, with Jean-Pierre. As you heard, Jean-Pierre works with Save the Children, has had more than a decade of experience of working to support programs in East and Southern Africa. So Jean-Pierre, could you say a little bit about the experiences you've had with programming, with policies, and particularly perhaps focusing on the issues around the big challenge we have nowadays is in the past a lot of standalone programs around HIV and other areas. We're increasingly realizing multi-sectoral integrated approaches are really what's needed in this field. So we'd like to hear your thoughts and experiences around these issues.
Yeah,
so, thank you.
I think you framed it very well. And to go back to the doom and gloom, I think starting with effective programming, we have to look at incidence data. I think that's a real starting point. And with adolescent programming, and especially in regards to HIV, it tells a very doom and gloom scenario. As you pointed out, 2/3 of new infections are adolescent girls. That's still 380,000 infections globally a year, new infections that are taking place. And this is despite the many breakthroughs that happened. Globally now we've got tenofovir as part of a first-line regimen for most combination therapy that is being offered within public health systems. PMTCT has been hugely effective. But we're seeing that out of all the different age groups affected by HIV, adolescents are the only age group that are still increasing. And since 2000, the increase has actually been threefold. So that's quite shocking if you think about it, with all the money and all the expertise that's been put into HIV programming. So so even as it's going with HIV program, even if the current progress is maintained, the prevalence is going to go up for adolescents. So how do we do this? How do we work with this? So with the growing number of young people living with HIV, we need to actually systematically meet their wider needs, as you'd spoken about. So going back to the discussion ongoing throughout these last 2 days, adolescents are a very diverse group. They're very nuanced. They differ substantially in knowledge, attitudes, and behaviors by age, by sex, by marital status, by employment, by life experiences. And even in the same context, an 11-year-old boy is remarkably different from a 15-year-old girl. And the needs and the capabilities that we're going to have to target have to really reflect that. In relation to their needs regarding HIV, these needs could include overcoming health barriers such as access to ART, disclosure of HIV status, testing, youth-friendly services. It could be psychosocial support, including disclosure of loneliness, discrimination that comes along with it, and then the most scary of all, transitioning to the adult world. Sexuality, forming their own families, barriers to meaningful work, all the various needs that we would have to target looking at this very nuanced group of adolescents. So targeted interventions are the next step and that needs to change and needs to be very directed. I think we've seen in traditional HIV programming, it hasn't been overly effective given that the large adolescent prevalence that we're still dealing with. Concern with adolescent programming is it often focuses primarily just on the prevention of HIV transmission. We know now, and we know from subsequent programming, that we have to focus very heavily on not just youth to prevent HIV, but actually youth living with HIV. There has to be a positive living component and sustaining them and retaining them on the continuation of care going forward. And not just having vertical programming. So I think previously with many health systems, specifically in South Africa where I grew up, there was this epidemic that was rampant, it grew quite quickly, and we had to really silo HIV programming in order to strengthen it, in order to give it the recognition that it needed. Now that it's 20 years later, there's a need to have more integrated programming within HIV, and in order to target specific vulnerable adolescent groups, being able to really incorporate that programming across the spectrum. So I just wanted to give some examples perhaps of how Save the Children has done this globally and some experiences that we've had with it. So Through our livelihoods programming, we've been able to empower vulnerable adolescents, specifically those who have lost parents to HIV/AIDS, child-headed households, and then adolescent girls involved in cross-generational, transactional, commercial sex exchanges, and have targeted livelihood, life skills components to have targeted employment opportunities that are specifically focused on these adolescents that have grown up with HIV, to almost try and mitigate the impact that they've had living with the disease going forward. Through education, we've had some strong probing examples in addressing the HIV stigma and discrimination in the learning setting. So this has been among teachers, among parents, school authorities, building into the learning materials. And again, not just the what you would call the basic HIV prevention, but the care and the treatment and the living positively going forward. It's also been through expanding outreach and education in school-based curriculums, linking to out-of-school activities, and really making it an integral part of the educational programming, not just an ad hoc component that could fall away at any point. Through child protection, we've included interventions to address the HIV prevention, care, and treatment needs of victims of abuse, young migrants, and adolescents in emergency settings. And there's been also a component through this working with very young adolescents. So again, another targeted, vulnerable group, age 10 to 14, very different needs to older adolescents, and specifically when considering the life stage that they're in. Then also through child rights governance, we've worked quite hard to promote the voices of adolescents living with HIV in establishing appropriate, acceptable, affordable, and high-quality youth-friendly health services. And again, ensuring that the rights of the people living with adolescents are actually met. And then I think, just as a wrap-up, as a final point, a large part of our programming is always focused on participation. And that's relevant to across the board, not just HIV. But I think in HIV it's very important for the point that, especially with adolescents, working with the nuances of adolescence and the very challenging behavior change component that is involved in HIV programming, it's imperative to involve the youth in this program design from the start and really identifying their needs and working with them to have strategies and going forwards and trying to reduce the barriers that they face on a daily basis.
Thanks for the broad programming approach there, and I think a lot of the examples you've given there are going to help us to think through how to go forwards, particularly working with adolescents, as you say, moving away from targeted approaches. A second area that we've learned a lot about, and we can continue, we, the community of more broadly and SRHR generally, is engagement with civil society. And this has been one of the major booms from and gains from the investments in working with HIV and AIDS. And Mark, you've been very, very active in this area in working with civil society, or you're an active member of civil society in your own country and globally. Kenya, like many countries in East and Southern Africa, has a lot of action going on. There's a lot of civil society activities, a lot of NGOs working. Government is also pretty active. Could you say a bit about your thoughts on what role civil society has to play and how things are working out in this environment where there are multiple actors, all with the same honourable goal, but working from different perspectives?
Thank you very much. Let me just start by saying, asking you to tell the person next to you, you were once an adolescent. Just whisper that. Don't be afraid. Even if they don't want to look at you, just tell them you are once an adolescent. I think being an adolescent and being a young person, it's a stage where you question a lot of things, and you also want to know you want to get a lot of knowledge, and sometimes if that is not taken care of, you can get the wrong knowledge. I think the role of civil society organizations in making sure that we end HIV and AIDS and bringing young people on board is making sure that you inspire young people to come on board, because you cannot force them. It is very important for you to inspire them. Let them see, let them know that it is important for them to be on board. And I've seen in the past, in my own experience, young people will be called to a meeting, they'll want to attend that meeting, but only because there's some incentives, not because they own that program. So personally, I think it is very important for us to make sure that as civil society organizations, we are bringing young people on board. And it calls for change in perspective, really, because most programs or a number of organizations will view young people or adolescents as program targets instead of viewing them as partners. And I think that is a very it is a big shift, and it calls for everyone to make that shift, to look at young people as partners instead of just targets for programs. And that, from that perspective, each and every move you make, each and every idea you have, you'll want to bring these young people on board, especially adolescents. For example, it has been said time and again in this conference that HIV and AIDS is the #1 killer for adolescents in sub-Saharan Africa or in Africa. And when you look at things on the surface, you wouldn't know, but I guess that is something that I actually think about every day. And I thought that if we do not involve these young people, these adolescents, in ending HIV and AIDS, then that is the greatest injustice that we are doing to them. So I think from the word go, it is important to involve young people by one, inspiring them to join your cause, sharing that vision, and also they can contribute. I was just talking to my friends last night, and I just mentioned to them, some of them like Justin Bieber, and I know some of you are very familiar with Justin Bieber. Justin Bieber made some of his greatest hits as an adolescent. I was actually, just looking at the pages of history, and I came across a guy called Sam Colt. Sam Colt is a guy who invented the revolver gun. And Sam Colt did this as an adolescent. So I can continue sharing very many examples of adolescents who have done exceptional work. And I think it will be wrong for us to ignore the gifts, the talents, the abilities, and also the energy, the creativity of adolescents, just by saying, hey, they're just adolescents. What can they bring on the table? So I think it is very important for us to tap into this resource, look at young people, look at adolescents as a resource, not just as an expense, and bring this power together, bring these resources together to make sure that we have a positive impact. So let me stop there for now.
Oh, thank you, Mark. Thanks very much indeed for raising a lot of important lessons there, and some of the principles that we need to think about going forwards. And I think the second, so from the perspective of what have we learned from the experience of addressing AIDS over the last 3 decades, engaging civil society much more strongly is one clear lesson. The other one is engaging with people living with HIV. And we're very fortunate to have Maluba with us, who is both a very, as you heard from my introduction, a very active adolescent, but also a very active, or maybe post-adolescent, maybe, young woman, but also a very active person living with HIV. And it's important to listen to what she has to say, because quite often we tend to forget that there are still a lot of stigma around in many societies around this issue, and to hear about her experiences around that, but also to hear about her thoughts about going forwards and how we can learn more from engaging with people that are living with the virus. So, Maluba.
Hello, everybody. So when my mother and father separated, I was born in London, England. When my mother and father separated, my mom brought me and my older sister to Canada. We actually came here to Ottawa in 1995, and I was 2 years old, and I started getting very sick, and the doctors ended up testing me for everything, and as a last result, tested all 3 of us for HIV, and they told my mom that she was HIV positive, but her 2 daughters were negative, and then about a week later, they said that the results were false, and that she was positive, and I was also positive. So from 2 years old on, that was kind of, because my mom is from Zambia originally, she thought that was a death sentence. She also thought that was something that you couldn't tell the public, so it was very kind of a hidden secret. When I was 14 years old, my father passed away, and then when I was 18 years old, my mother passed away, and because of, like you said, the stigma, and also I saw this, I didn't think there was any resources out there for me, and I saw both of my parents pass away from a virus I was living with. I kind of decided, well, I'm 18 and an adult now, I've decided I don't have HIV anymore, and so I lost out of care, and that actually, now that I can see going back doing the research, that actually happens to a lot of adolescents that are born HIV positive. When they become adults, they do tend to fall out of care. Sometimes the transition isn't right, going from pediatric care to adult care. And sometimes the stigma is just a lot as well, as talking to these adolescents about sex, talking to them about all those things to go on beyond life. And it's also a conversation that a lot of people do think it's through sexual transmission. You don't think about getting it through mother to child. You don't think about getting it through breast milk. And also, you don't think about getting it through a marriage. You know, my mother was in a monogamous marriage, or so she thought. But those are conversations that you do need to have too, but that are very tainted. You don't want to talk to anybody that's married talking about getting HIV tested. That's an insult. And so those are conversations that I'm trying to dispel and start to have conversations, but that's where the difficulty comes. And I always tell people now, it almost does feel like the stigma is almost getting greater than the HIV, because that's still something that stops the conversation from going forward. And to reiterate what both of them said, just really having youth and adolescents at the table, because I think out of the biggest programs that I've seen that have been successful, it's when they're at the beginning of it, when they get to implement and plan it out. That's when they will show up for it. That's when they will be a part of the resources.
Well, thank you. Thanks. Thank you all for your contributions. We have some time now for questions. So please, do we have any questions from the audience for the panelists? I know it's been a long day, but we have one here.
Hi, I'm Graham Dobbs from McMaster University, and you guys had mentioned that youth HIV prevention is one of the most effective ways of reducing transmission and reduction in later life. But I have some questions on what are some long-term pathways you guys would recommend or are already being used to perpetuate the knowledge or the effectiveness of these youth HIV prevention programs. And also, what outcomes best measure reductions in HIV prevalence? And I think I'm asking this because this may give policymakers the evidence to scale up the best programs and continue to reduce transmission and harm.
Thank you.
Sorry, it was a bit loaded.
Perhaps I'll jump in for the first part of it. What we've seen with programming is, as far as really driving change, there has to be a very strong health literacy component as part of really having meaningful behavior change, meaningful norms change. And around when HIV first started being an emerging issue, there was a huge focus on treatment literacy. And treatment literacy was around getting the patient to feel empowered to demand an HIV test, to be able to demand that they've got a constant supply of ARVs, to be able to go to the nurse and tell them that they've got certain side effects and ask to be put on a different regimen if they have to. And the treatment literacy component was very difficult, dealing primarily with people who perhaps didn't have formal education, who weren't able to speak in English, weren't able to properly express themselves to these formalized health workers, and there was this big divide between the informal and the formal. Now, taking it further to health literacy, that's also got a huge prevention component to it, where people do understand the risks that are involved. There's an understanding of the risk aversion that you can have, of the steps you can put in place to buy to your medication, and I feel that is like the underlying core of a lot of programming that isn't followed through on, is really getting a properly understood treatment literacy component and health literacy component that's linked to the behavior change programming.
Thank you.
Thank you.
Hi, Katie Lee Lloyd from CanWatch. Thanks for that very interesting panel. My question is around furthering thoughts around solutions, including in populations that are hard to reach, whether that's because they're in fragile contexts or because they don't have access to health service providers. I know one thing I've heard of, and perhaps you could speak more to it, is there's I believe now a vaginal ring that can prevent HIV transmission, and I think you need to replace it only every few months. So that's, would love to hear expansion on that and any other solutions you have for those harder to reach contexts. Thanks.
Sure. Mike, I can talk a bit about that particular question, but does anyone, either Maluba or Mark, did you want to pick up on any of the previous question, or do you want to go ahead? Or no? Okay. Mark, do you want to say anything?
If I got your question right, you're talking about the hard to reach. I think every context, every area has its own, challenges and opportunities in some contexts. For example, I think in some as much as, for example, let me give an example of Kenya. Kenya has some parts of Kenya, are really affected by poverty, and some are well off. But you'll be surprised to find that technology can turn out to be the best way to reach out to these people. And so I think it calls for use of these innovative approaches, maybe which are sometimes tend to look like they're not really the most appropriate. But I also think having young people on the table, making such decisions, and also, looking into such options with them can help a lot in identifying the best approach. Because, for example, we can choose to play poker with Sean here, but maybe he wants to play it using an iPad, or maybe play with someone else via online. But I think it is, having such a well-informed background that we can actually have successful outreach programs which are reaching out the specified target. Yeah.
In terms of prevention, I mean, there's a whole area we can talk about there, but you mentioned particularly some biomedical approaches. I mean, in the biomedical area, we basically have, I guess, three options. One is vaccines, and we're still a long way to go with that in terms of HIV. We heard earlier about the HPV vaccine, and we're currently starting work now on other vaccines, particularly for HSV. There's a group now working on vaccines for herpes. Obviously, the challenge there is how to deliver vaccines and how to ensure that they reach the right audience, the right populations, because do you vaccinate an entire population or certain populations, and when do you vaccinate populations from a programming perspective? And for adolescents, we heard earlier about the importance of using adolescence as a time for providing HPV vaccines. And then we could also argue, well, maybe if we're going to be developing a herpes vaccine, then that should also be, maybe there could be a package of vaccines that are available. And so in addition to the child, the infant child vaccine period, we have another vaccination period to do with sexually transmitted infections around the period of puberty. Secondly, we have some barrier methods, very few, condoms primarily, and male and female condoms. And then, as you mentioned, we're now having some microbicide biomedical products, and how they are presented, how they're used is the challenge. Some are being tried in terms of, as you say, these vaginal rings that are used, and they can be used to provide both the microbicide and contraception, contraceptive hormonal contraception. And then also there are applications using gels and creams and so on. But the other area where we hear a lot of investment in is more on behavioural and social behavioural interventions, and we've heard quite a bit about that already from my other colleagues. But it's an area where that's still the big challenge inevitably. Human behavior is very hard to change. And we have some experiences, but it's still hard to know what works at a large scale. So there's those issues. Do we have other questions? Sorry, yes.
Yes,
Natalia,
thank you.
please.
It's Natalia Kanem. I'm with UNFPA. I wanted to congratulate the panel. It's been practical, but you also feel like you're getting the latest. That's been great. And it was also nice to have the contribution of someone with direct experience. I wanted to mention that HPV was noted this morning as highly cost-effective when you look at return on investment. And to mention that as UNFPA has been involved in some of the testing, some of our parents are suspicious as to why girls are getting something that boys are not getting. If it's all that great, typically in the gendered world in which we dwell, the opposite holds true. But I suppose that boys could be vaccinated against HPV cost effectively as well. So I just wondered how you think about that dynamic. Thank you very much.
Thank you. Does anyone want to contribute to that one? I'll give it a go, but if there's others in the audience who would like to say something as well. You're absolutely right that HPV vaccination for boys is an obvious way to go. I think that the challenge is a cost issue and a coverage issue. And I think the idea is let's go with the low-hanging fruit first. And vaccinate girls, but at the same time work towards approaches to reaching boys. And which gets back to my earlier comment about any vaccination program, who gets vaccinated, who doesn't get vaccinated, at what time, and in through what mechanism. So those are a challenge. And HPV, it's one of the really good things about this is that people are getting the message that it's cost effective. And you've mentioned it, we heard earlier about benefit cost analyses. And rightly or wrongly, this is such an incredibly important piece of evidence that we do need, because it resonates with the people providing the resources. And so also I'd like to know from the panelists if there's any thoughts around the cost benefits, the cost effectiveness of the types of approaches that you're familiar with. What do you want to?
I agree with you. I think things that when I've asked the same questions is just kind of the low-hanging fruit, get kind of the most vulnerable first. So hopefully it's coming eventually, but I think it's along the same lines of what I've heard and spoke with people about.
For me, I think that question I might answer it with the perspective of a young boy in the village who is now wondering, what is this HPV you're talking about? What are you talking about? Are you just saying HPV will benefit me? How will it benefit me? So I think as much as we're having all these nice strides, it is important for us to make sure that someone doesn't confuse HPV for PEP or anything else. So, and I think earlier on or yesterday I had someone say that we must bring down all these terms into, or package them in a way that these young people will understand, so that we can also increase the uptake of that, all these commodities like HPV. So for me is to, ask us to make sure that, it's upon us to make sure that we have created that much awareness to a point where we do not just have stock for these vaccines, but we also have uptake. So, and I think that will come about by creation of demand through creation of awareness. Yeah.
Thank you. So I have one question and a second question.
Yeah, from CanWatch. Thanks so much for your presentations. I'm interested in knowing a little bit more of the panelists' thoughts on how the HIV and AIDS movement has been so successful. So we've seen a lot compared to other diseases. We've seen a lot of success in this area in decreasing incidence. So I'm wondering, how do you go from kind of the personal experience to building a movement? What are some of your strategies? What's worked? And just a few more thoughts on that so that we can take that into other movements.
It's a big question. Do you want to go?
Personally, in my opinion, is, like you said, I think it's something called JIPA-MIPA, which is the greater involvement of people living with HIV and AIDS, or meaningful involvement of people living with HIV and AIDS, and I think always putting them at the forefront. If you get one person, especially if you're doing adolescents, there are adolescents that are infected or affected with HIV and AIDS. They're not exactly out there screaming it out, but they are there, and I think getting them into the community, I always tell people that it's just one voice. If you could just get one person from the community and educate them and have them kind of be your source, that can greater grow. I think HIV and AIDS, like that movement, has been successful, but it's also been very slow, because it's not something where you can always just grab everybody and get their attention, because it is something that can still be difficult to talk about. But if you can grab one person and kind of outspread it like that, then it becomes a really successful thing. And I think getting facts and information correctly definitely works.
My own opinion in that is I think that HIV, besides the fact that it hogged the spotlight and substantial funding for such a large amount of time, is that it had a very strong civil society. And this was linked in particular, firstly, to obviously young gay men not being able to get treatment in San Francisco, and then within sub-Saharan Africa, many of the health officials not recognizing HIV being linked to AIDS, and being the emergence of like the Treatment Action Campaign, Treatment Action Group, and these really large, strong membership organizations that were able to link up globally. And these were made up of scientists, these were made up of very influential people who were really able to drive that agenda forward. And I think what it did for the discussion globally is it really destigmatized it to the point of view that it was on mainstream news, it was discussed, and I would attribute a lot of that to the civil society participation.
Mark, do you have anything to add? Do you have anything to add, or should we take the next question?
Oh, yes. In creation of a movement, first of all, you have to make young people aware that for us to bring solutions don't just come from adults, but they also come from young people. And also that goes back to the point that I made earlier, that young people should also start seeing themselves as potential partners and people and individuals who can create positive change. And I think from that individual perspective, that's when they can make that initiative to come together and make an impact. And from that now, I think a movement can be birthed from it. Yeah.
Thank you very much. We have time for one more question, so please.
Thank you. My name is Alvaro Bermejo, and I'm now at CIF. And have worked for many years in HIV, and one thing I've seen change in the 20, 30 years I've been working in HIV has been the ubiquity of porn now, and the fact that wherever you are in the world, access to porn is quite easy. So, and in these 20 years, I think we pretend that that hasn't happened, that sexual practice hasn't changed. And while we've changed very much the way we talk about sex in the last 20 years, we still hardly talk about heterosexual anal sex. So anal sex remains a taboo, and there are very few organizations implementing programs that are particularly targeting heterosexual anal sex. And we know that it does play an important role in transmission. So I wanted to ask the panel, how do we turn that around? And if it's not through Adolescents where we start, how other way? And in this conference, I don't think, at least I haven't heard it even named, which is a typical example of what happens in conferences like this. So wanted to hear the panel's reaction to that, or if you have, maybe you do have a lot of experience in sort of implementing programs, particularly looking to address this.
Thank you. Does anyone want to?
In my experience, personally, that is something that I've heard about. When I was 17 or 18, I learned about it, and that was through a comprehensive sexuality education program. But today in our country, we have a ministerial commitment on comprehensive sexuality education. But I don't know how about, I don't know how, what those other countries are doing, because you cannot just, for example, let me give an example of Kenya. You cannot just come and start teaching or speaking about heterosexual anal sex. And I think the best, the best platform for you to talk about these issues will be in the context of comprehensive sexuality education, where you're naming all these things. So unless we have such a platform which provides, an opportunity for adolescents to learn about it and also to understand all these dynamics, it will be a bit difficult for that to be done. And that goes for very many other African countries which are burdened by HIV and AIDS. But I think moving forward, it is something important to mention and also include in our discussions and make sure that we include it and we prioritize it in terms of making sure that adolescents and young people are able to understand all these dynamics and not just the basics, because we are living in the information age, and it is very important for us to share all this information on a factual basis, not just based on opinions. Yeah.
Just to conclude, because we only have about a minute and a half left, I think that the point you're raising is very, very important, because a lot of the time when behavior change interventions, to use that jargon phrase, are designed and then implemented, they focus on who you have sex with, how often you have sex, when you have sex. They don't talk about how you have sex. And the how you have sex is often the most important factor. And that is something which is not addressed. It's a topic which people find very hard to discuss openly. Thanks for bringing it up in this session. As a researcher, we have very little data on this. I mean, surveys don't ask those sort of questions. They ask the sort of things I've just talked about, but unless you go back to Kinsey-type surveys, we don't learn about that. But it is such a critical part of understanding transmission and prevention, for sexual transmission, obviously, that it's a very open and missing area. So thanks for raising it. I'm also very aware that you have to run for your train in the next few seconds. So I'd like to thank very much indeed the panelists for responding to your questions, for sharing their experiences. And thank you to the audience too for raising questions. And I know we have to finish now. So thank you all very much indeed. Thank you.